everyone. I'm Dr. Abdulrahman Qahtani. I'm the head of interventional cardiology at King Fahd Medical City. It is my pleasure to be opening this session today with this challenging bicuspid aortic valve case. So I had the pleasure of meeting a 75-year-old lady with a background history of dyslipidemia and hypertension. This lady was diagnosed recently with ovarian cancer, and she was requiring a cytoreductive surgery. Her prognosis was more than 1 year, and we were involved after she was diagnosed with class 2 to 3 shortness of breath, heart failure, and examination was suspicious for a severe aortic stenosis. She underwent an echocardiogram that, as you can see here, that the aortic valve is heavily calcified and restricted, and there is evidence also of moderate aortic regurgitation. The LV function was normal. The gradient across the valve was around 52 millimeter mercury, and when you look at the valve itself, it's hard to discern if this is a tricuspid valve or a bicuspid valve. Our colleagues from ECHO were not able to say for sure if it's a bicuspid aortic valve. But by the way you look at it, you could see this heavily calcified area that could be a raphe around 1 o'clock. It's jamming. Okay. CT scan was done for this patient, and the perimeter of the annulus was around 74. And when you look at the 3-volume rendering or the hockey puck shape, you suspect this is type 0 kind of a bicuspid aortic valve. When we did the measurement at 4 millimeters, the intercommissural distance was 23.8, and at the level of the annulus, it was almost the same. The average was 23.8. So there was no difference in terms of sizing in this patient. The angle was more of a horizontal angle, more than 49 degrees. And that adds to the challenge in a bicuspid aortic valve. The coronary height were appropriate, about 12.3 in the left main and 14.7 in the RCA. And the peripheral axis was good. There was no significant disease or anything to be concerned of from a peripheral axis point of view. So this patient was brought to a combined meeting between cardiac interventionist and surgeon. And because of her age, 75, her STS score was toward the low intermediate risk. She was frail. She had mild COPD that we didn't mention earlier, and also the ongoing ovarian cancer. After discussion, surgeons declined her, and she was accepted for TAVI. So we brought this patient for TAVI, and we're trying to discern the best angle we can. It was not easy to discern them, especially in those patients. Sorry, it's going faster than usual. So first we started with the pre-dilatation given the situation that we had. And it was important to do that because of the degree of the fusion that we suspected, and it will interfere with our ability to deploy the valve appropriately. So we did that, and then if you look at the position of the valve here, you could see the valve before we deploy it was, it's going faster than what we're supposed to have. So you could see when we try to deploy it, I'm just going to go from here, it's keep jumping down. And when we try again, retrieve it and try again, it keeps jumping down. And the reason for that is just because of the radial force exerted by the area where you get the fusion, either commissures, that cause significant radial force for the valve to keep diving down. So we got this position. We thought this might be a good position to deploy the valve. So we went ahead with that. And here, where we release the valve, I want to show you one thing. Look at the position of the valve before we release. And the moment we release the valve jumped. Look at the position right now. So this is, we still have a parallax in this situation. And when we remove the parallax, look how deep is the valve in this situation. What we can see here that there is at least 2 to 3 plus aortic regurgitation based on that. So we did bedside echo right away, and we suspected to be moderate to severe paravalvular leak at that time. We decided that the patient was stable. We'll send them to recovery. We'll wait for 1 day, get the valve a chance to warm up and expand further. And the next day, we did an echo, and look how significant is that paravalvular leak. So you could see it swirling around the valve. And around on the short axis, you could see was around 1 o'clock, the majority of it, and it comes and swirls around the valve. Anyway, we decided since the patient was stable, she needed the cytoreductive surgery more urgently. We discussed it with the oncological surgeons, and they agreed to go ahead and do their surgery. So I saw the patient 1 month later. She was not having any heart failure symptoms, but when I repeat the echo at that time, she still have what to be severe paravalvular leak in that situation. Given the severity of the leak, we decided that we need to re-intervene. So we brought patient back for another procedure to try to remove them. So the first things about this is, given the position of the valve and horizontal aorta, we needed to ensure that the valve will not dive down into the LV when we try to bring the new valve, because we were expecting to have significant friction between the new one and the second one. And we had to place a snare on the core valve to stabilize it from going to the LV. And we managed to bring it, but it was challenging to get it in. But once we get it in, we were okay. And when we start deploying, as we can show you here, it's keep going up, but we bring it back until we managed to get in this position. We had some parallax here, and intentional parallax, because we needed to see where we're deploying in both angles there. And that's the position we got into. And here, the position we have. You want to appreciate this very well, but that was just before we released. We wanted to make sure that we are in a good position. And then we released, and you could see there is no significant paravalvular leak. What you can appreciate is our new valve is at least half a cell higher than the previous position. And with this, we managed to get rid of most of the paravalvular leak. Actually, we don't see anything. I did not mention this earlier, but look at the aorta. The aorta is actually dilated. It was 4.5 centimeters and was adding to the complexity of the case. I saw her 3 months later, and this is her echo 3 months later. I'm just going to stop here. You could see there is still a small paravalvular leak located at the spot where we saw most of the problem. So just a little bit about bicuspid aortic valve. So bicuspid is not a tricuspid. The cusps are more calcified. There is more calcium deposit. It exerts mechanical and tensile stress on the bicuspid aortic valve if you deploy it. The annulus is not a regular annulus. It's more large, it's elliptical, and there is also evidence of calcification. The raphe itself is asymmetrical and could be heavily calcified. They might get commissural fusion. Also, there is issues related to the aorta. There is horizontal aorta, there is dilated aorta, and you might have corticated associated with that. Commonly used severe classification for classifying the type of bicuspid aortic valve you're dealing with. And in this patient, we were suspected to be type 0. But there is also a different type of classification based on the CT imaging, and it could be used, and it has its own utility. So if you want to consider TAVI for bicuspid aortic valve, should we consider it? What's the surgical risk? What's the morphology of your bicuspid? This is important, especially when it comes to morphology, because we know that the outcomes is related to type of the morphology that you have. So if you have a patient with calcified raphe and excess leaflet calcification, their mortality from any cause is significantly higher compared to a patient that has no calcified raphe or excess leaflet, 25% to 5.9%. So what's the data for TAVI? So the association of mortality or stroke between bicuspid versus tricuspid was looked at in a propensity-matched scoring from the registry, from the SDS registry. And what they found that patients with bicuspid are having a longer procedure from a fluoroscopy point of view. There is trends toward higher conversion to surgery, trend to higher aortic rupture. This was a Sabian registry, and the need for second valve. When they looked at 30 days mortality, if you are dealing with bicuspid, you're more likely to deal with more stroke and more pacemaker. But there is no difference in terms of all-cause mortality. Because you're dealing with a stroke, you do pre-dilatation, there is heavy calcium burden. Also, the brain injury associated with bicuspid, as been shown previously, is more common in bicuspid versus tricuspid valve. So if you decided to go with TAVI, what type of transcatheter valve that you're going to use? So this is a systematic analysis in 2018, looked into TAVI and bicuspid in all generations, Sabian, XT, and core valve. And in this meta-analysis, it showed that paravalvular leak is significantly higher, up to 10 times fold increase when you use older generation, Sabian, XT, or core valve. But another study that looked into that, the outcomes, transcatheter aortic valve replacement, bicuspid aortic valve, a report from the STS showed, are we running out of time? So basically, it showed that the newer generation does not have the same issue with terms of paravalvular leak. So this was a case of challenging bicuspid aortic valve in terms of the angle, in terms of the aortopathy, in terms of the type of bicuspid aortic valve. Paravalvular leak is real and it's commonly to happen. And trying to deal with it by pre-dilatation before trying to open the valve, but sometimes it's not the case. In our case, we had the valve dive down and we had to basically try to fix that later on by putting another valve. Considering another approach which is rarely used, trying to put a paravalvular plug, it's not going to work in those patients. And thank you.